Okay.
So this is Harold Pollack. Welcome to another edition of Curbside Consult, and I'm delighted today to have Avik Roy here to discuss with me his new health plan, Transcending Obamacare.
Hi, Harold. How are you?
Very well. So why don't we start by just describing sort of how this plan came to be, and we'll give a 50,000-foot discussion before getting down to the 7 inches level of detail that I'm sure we'll get to in not too long.
Well, my view, let's start going back to 2012. So my view, and I think the view of most people in 2012, was that if you wanted to repeal Obamacare, as nearly all Republicans had sought at that time, you had to win the 2012 election, because if the president was reelected, President Obama was reelected, then the subsidies, et cetera, the whole exchange system, everything would go online, the Medicaid expansion, and I think we all have a view based on history that once a large program like that goes online, it's not something you can just simply repeal. At least that was the view that Republicans had in 2012, and that's why they put a lot of energy into trying to win the 2012 election.
Mm-hmm.
And
Can
I
you just
actually,
review, by the way, who won the 2012 election?
President Obama.
Thank you. I just wanted to get that on the record.
Yeah,
You may
no.
continue.
That's fine. So President Obama defeated my guy Mitt Romney, who I advised in that election. So you can blame me for the fact, or thank me for the fact that President Obama won, depending on your point of view. But I felt then, even going into that election, and certainly once it was over, it was clear that in my view that Obamacare was here to stay, and to me. That wasn't all doom and gloom for conservatives who care about healthcare reform, because my view had been then and is now that exchanges, or let's put it another way, the use of tax credits, refundable tax credits, to subsidize coverage for the uninsured with private insurance is the ideal way, in fact, to have a true safety net and provide coverage for the uninsured. So my hope, and perhaps it's an unrealistic hope, but my hope is that the fact that the left, and let's just say at least certainly Democrats, mainstream Democrats and their allies, have been so energetic in their defense of tax credits for the purchase of private insurance, that this could be an opportunity for bipartisan cooperation, in fact. And there are more cynical ways to look at that. You know, the left that complains that, well, it's all really a conservative idea. Obamacare is a conservative idea, therefore, blah, 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 blah. And I mean, however you look at it, it seems to me that, you know, the way I've put it in a lot of my op-eds recently, is that Paul Ryan's plan for Medicare reform and the Obamacare exchanges are actually very similar if you strip away the party affiliations of the people who have proposed them. And in fact, Paul Ryan's plan for Medicare reform comes from Democratic scholars like Henry Aaron and Bob Reischauer. So there's a bit of a flip or inverted scenario there as well. So the whole point of all this is to say that exchanges or tax credits for the purchase of private coverage is an attractive centrist solution, shall we say, to the problem of the uninsured. And my argument had been that, looking at systems like Switzerland that have shown excellent fiscal performance using such a model, that this could have solved, that we could actually solve both progressive goals and conservative goals, is to say expand coverage while also putting the fiscal situation in balance at the same time, and you could even do that while reducing spending. And so there were a lot of opportunities to actually bring both sides together with such an approach. And again, from my point of view, it's very important to have something that can actually attract support from both parties. And so I wrote a piece for National Review in November of 2012 or December of 2012. I think it was officially published, explaining this, because Rich Lauer, the editor of National Review, had asked me to write, okay, what should we do now? Write a what should we do now kind of piece. So I did that. And the reaction was interesting from both sides. I think people on the left were like, well, see, there goes the Obamacare surrender by the right, and the conservatives were like, some of them said the same thing, and some of them said, no, this is actually extremely interesting, and maybe there is a path forward for conservatives. But it was clear in those ensuing months that nobody else, with the lone exception of Doug Holtz-Eakin, the former CBO director, in a piece that we wrote together for Reuters, almost nobody else on the right was interested in joining me in articulating this concept or exploring or fleshing out this concept, even if they might sympathize with it in private. And so I realized that it really fell to me to develop the concept as extensively and as rigorously as possible. And so I spent the next 21 months, effectively, from November of 2012 until now, August of 2014, doing just that, developing the concept, really trying to think through and work through how one would actually do something along these lines, which is deregulate the exchanges to a degree or reform the exchanges so that the cost of insurance plans on the exchange can be more affordable, and then gradually migrate people on other programs like Medicaid and Medicare onto these reformed exchanges as a means of entitlement reform. That's basically the simple kind of architecture of the concept. But as you know, Harold, the guts of it are a lot more complex and a lot more detailed than that. And that required a lot of work. So it required fleshing out qualitatively what kind of policy you would want to do that, and then working with as many people as were interested in reaching out to me, including you, as you know, to kind of think through all the details of how this would work, try to figure out what are things I wasn't thinking about that other people were, things I was overlooking, technical considerations I hadn't thought about, and to model it fiscally, to use the best outside, that is to say, non-governmental sources to model fiscally how this plan would work. So all that took a long time, and then writing it up, it's a 20,000 word monograph. But I thought, you look at some of these plans that Republicans have put out, they tend to be, say, 8 pages with a lot of bullet points. And my goal here was to put something out as detailed as I possibly could and still have it actually be read by people. And that way we can litigate these ideas and think them through. And if there are things that need to be improved or revised, this is the time to do that. Take a couple of years, put it out ahead of time, and see how it can be refined.
So this is Harold Pollack again at healthinsurance.org, and I was about to say healthcare.gov. That would be the wrong website. And I'm talking with Avik Roy about his new health plan. I do think that progressives should carefully read this. I think I and others will disagree with a lot that's in here, but I think it's extremely valuable to see what a conservative vision would look like that does have near universal coverage and some of the elements that make it at least a basis for conversation, and it's explicit in the areas where we would disagree. And it's actually fairly radical in terms of what's going on in Medicare in some ways, and we'll get to that. But I want to start with a few areas where we actually probably agree, or at least have some basis for agreement. One is the Cadillac tax, which you keep in your plan, although you would just, in fact, you would start it sooner and you would get rid of some of the negotiated arrangements that essentially Democratic interest groups made in the passage of the bill. And I must say that, to me, this is a political issue that has to be negotiated with a lot of stakeholders. But the idea of limiting the tax expenditures to people like you and me for health coverage is a very sensible idea. And I think most health economists would agree that something of this structure, there's a lot of revenue there, and there's a lot of economic inefficiency there that the current system promotes. And I was happy to see you keep that. Now, I'm sure that the Cadillac tax is unpopular. And so I think you and I may both lose that one in terms of what happens in the U.S. Congress there. But I like that. I thought also there's less disagreement about how Medicaid and the exchanges should work together than there might appear to be on the surface. A lot of conservatives would like to see less emphasis in the Medicaid expansion on traditional Medicaid and more emphasis on putting people into the new exchanges. And from my point of view, I don't see anything for basically healthy low-income people, particularly, that seems to me to be fine. That there's nothing. In fact, Medicaid managed care looks a lot like what people might potentially get on an exchange anyway. So I think if you ask a typical Medicaid recipient in many states, what does your life look like? They may well have an Anthem insurance card anyway. And so I think to some degree, maybe it's useful that there's an apparent disagreement between Democrats and Republicans, because then we can use that as a basis of an apparent concession to get things moving. But I thought that was also something that was that was fruitful. So I do think that there's a lot in here that people probably that there is bipartisan potential agreement on.
Well, I did
Am I
make
hurting you, by the way? Maybe I should attack your plan more aggressively. I should say for our readers or listeners that you and I have tangled many times, and I was a very strong supporter of ACA, and you were on the other side. So maybe I should attack you more aggressively.
Well, I'm sure all your readers who follow healthcare policy well probably already think of me as their bête noire, so it may not be necessary. But I would say that well, first of all, let me just dispute your characterization of the plan as radical in some ways. Actually, I would say that, and we can talk about this later.
Mm-hmm.
I think one thing I really emphasized in the design of this plan was gradual evolution of the healthcare system in a different direction. Is the end result different than the system we have today? Absolutely. But it takes 30, 40, 50, 60 years to get to that point. And that is okay, because from a standpoint of the fiscal situation that I'm fairly concerned about, that's what you need. So long as the directional, the long-term problems are addressed, that's what the financial markets, that's what the debt markets in particular need to have confidence that the U.S. government's not going to go bankrupt. And also it helps us protect and preserve the promise to the people who depend on these programs today that those programs will have the financial stability they need to be there for them tomorrow. So that's a big part of what I'm really trying to do here, is to preserve and protect people's existing arrangements, and yet gradually, with as much voluntarism as possible, evolve those arrangements in a different direction for future. So, for example, a guy like me, who's 41 years old, I don't expect to have Medicare in its current form when I'm 65, because I know that in 25 years the country is going to be in a lot worse fiscal shape than it is today, and one way or another, these things are going to change. In terms of the Cadillac tax in particular, since you started with that, let me say that I'm more confident than you are that the Cadillac tax in some form will be there, because it's such a big chunk of the revenue stream or the funding for the ACA in its current setup that you can't repeal the Cadillac tax without offsetting that in some other way, either through substantial spending cuts or other tax increases. And so given the policy appeal of something like the Cadillac tax, I would be very surprised to see it repealed. I think what you could see, when I talk to Republicans or conservatives about my plan, what they say is the Cadillac tax is really kind of kludgy and clunky. Why not replace it with a standard deduction of the kind that economists have long favored as a replacement, a gradual replacement for the employer tax exclusion? And as I noted in the plan, I'm okay with that, as long as the fiscal effects are the same. But Edmund Burke once said, if it's not necessary to change, it's necessary not to change. And I think I've tried to apply that principle in my approach to health reform, which is to say the Cadillac tax is already there. Since the policy outcome of keeping it versus changing it to a standard deduction is not that significantly different, just keep it as is. And since I'm doing a lot of other things or proposing a lot of other changes, let me at least find excuses where possible not to change things.
So let me talk about the fiscal issues for a minute. One thing that's not as clearly stated in your document as it should be, and I think in your rhetoric, this is one area where you and I disagree, is the actual cost of the things that people fight about in health insurance. The Medicaid expansion, the exchanges. Those are not very expensive compared to the real money in healthcare is in the elderly and the disabled. And in fact, if you look at, I happen to have in front of me table 1.1 of a CBO document, which just projects out the cost of Medicaid, CHIP, and the exchange subsidies out to 2040. And what's really surprising about that to many readers would be that with all the ACA stuff, the increase is 1.5% of GDP. And it's very little. Once ACA is fully engaged, the actual cost of getting low-income people into the exchanges, expanding Medicaid for the low-income population, the things that were ideologically the most polarized, that's not where the money is. The real money, in fact, the real money you save in your plan is really in Medicare and in those features. And So
Yeah, so in page
go ahead.
14 of my monograph, Figure 3 has a pretty similar chart. It describes the increase in spending for the coverage expansion of the ACA and overlays on top of that legacy healthcare spending on Medicare, Medicaid, et cetera, to make exactly the same point that there is this perception among conservatives that Obamacare is a government takeover of the healthcare system. And it certainly expands, no one would dispute, that it expands the role of government in the healthcare system. But it's very important, in my view, that conservatives understand that the government has already been heavily involved in the healthcare system. And the real step change was in 1965 with the passage of the amendments to the Social Security Act that created Medicare and Medicaid. And so if conservatives want to tackle of government involvement in the healthcare system and rationalize government involvement in the healthcare system in a more efficient way, it's very important for conservatives to understand that actually there's a lot of conservative voters who benefit from government involvement in the healthcare system, particularly on the Medicare side. And that's something that a lot of conservative voters don't understand because no one has been telling them that.
Well, I think that they don't want to understand that as part of it. There's a huge element of cognitive dissonance going on where the Republican base is so weighted towards, an older group of white voters, many of whom are on Medicare, and who are actually the group of people who are the largest beneficiaries of the most imbalanced government transfers in a life cycle sense.
I think that's right, and so that's something that when I present, I have a PowerPoint that I give to conservative groups and Tea Party groups about my health care plan, and I lead with those charts, and I explain to them how much how much the federal government was already involved in the healthcare system, and how so much of that was driven by spending on them. And it's something they don't realize. People say, well, I get asked often when I do interviews on conservative talk radio or certain cable networks, they'll say, oh, but don't you think that Obamacare is the Trojan horse for single payer? I'm like, do you realize that 90 million Americans were already on single payer health care before Obamacare? And yes, Obamacare expands the single payer component of the healthcare system by expanding Medicaid. But that's not a Trojan horse. It's spelled out in Title I. So that's having that sense of proportion as to what Obamacare is doing to the healthcare system and what was there before. To me, that's the first step in helping conservatives understand where there is common ground for reform. Because if conservatives believe that Obamacare is the government takeover of the healthcare system and the government wasn't doing anything before then they're going to obviously support repeal of Obamacare and go back to the status quo ante. However, if they understand that actually the government's been involved in a lot of different ways and been distorting a lot of different things, then you can actually start to have a constructive conversation in which you say, okay, here are all the things the government is doing. Let's all agree that we want the poor and the disabled and the sick to have a safety net, but we don't want to spend your hard-earned taxpayer dollars subsidizing health care for Mitt Romney and Warren Buffett. So if we all agree on that, surely we can come to some, interesting approach that would be different from the kind of the box that conservatives have locked themselves in here.
So is this, and again, this is Harold Pollack on healthinsurance.org. I'm talking to Avik Roy, and right now we're talking about Medicare, and in a sense how your plan is really, it's using Obamacare in a sense as a platform to go after things that you don't like about the existing healthcare system before Obamacare, particularly its Medicare, sort of the heavy setup of Medicare on autopilot for older Americans.
Upper income Americans.
Yeah, including upper income. And so your plan, in a sense, says we're going to use the exchanges as a platform to essentially, over time, raise the age of Medicare and effectively use the exchanges, the subsidies within the exchanges, so that lower and middle income older people get subsidized, but increasingly older people would have to essentially pay their own way in Medicare. Is that an accurate description?
So the important thing, of course, to understand about the exchanges is that exchanges offer premium support subsidies to anyone below a certain income threshold. Under the ACA, it's 400% of the federal poverty level. So the idea here would be that upper income retirees who are younger would be expected to to either, quote unquote, pay their own way, as you put it, or stay in the workforce, in which case their employers could continue to sponsor their health coverage. So it wouldn't just be up to them, to just pay for it directly necessarily. But low-income people and low to middle-income people would still be protected by the same system that the ACA creates for people who are 64 and 63. And so my argument effectively is, if it's humane to offer ACA-subsidized exchange-based coverage for 64-year-olds, surely it's also humane to offer the same type of coverage to 65-year-olds, especially if it guarantees the permanent financial solvency of the Medicare trust fund. And this is an important point. So current retirees, if you're already on Medicare, these changes don't affect you at all because you're already past the retirement age. The gradual raising of the eligibility age for people my age doesn't affect people who are currently retired. So if you're on Medicare today, this change does not affect you at all. It'll affect people like me. People like me won't be eligible for traditional Medicare until later in life. But if I'm low income, I'm still protected. So effectively, the net effect of this is to substantially increase the amount of redistribution in the system. Instead of subsidizing upper income retirees, we'll continue to subsidize lower and lower middle income retirees, but not upper income retirees, who again will have the incentive to either stay in the workforce or pay for their health coverage themselves.
And I must say, to my surprise, I'm somewhat ambivalent about this. I'm surprised because you might expect me to more harshly disagree with you than I might. It is a massive shift of cost and financial risk off of the federal government onto various other payers and individuals. And there certainly would be, it's not clear to me that, the political fight that this element of your plan would create is enormous. And, it seems to me that this would, it's not, I'm very curious how Republican presidential contenders are going to, whether they're going to run from that or embrace it.
Well, they did, to their credit, whatever you think of the Paul Ryan plan, everyone thought that, that was going to be suicide for House Republicans when they enacted that budget in 2010, and they got reelected in 2012, and they look like the House majority is not, in danger in 2014. And Mitt Romney and Paul Ryan campaigned on this approach, or not my approach, but on an approach that's somewhat similar in 2012. And Republicans lost every other demographic except for older Americans.
They did, but of course I'm sorry. Go ahead.
No, I was just going to say that I think the key insight of the Paul Ryan approach to Medicare reform is that you don't make major changes for current retirees. If you're already on Medicare and you're already relying on the program and you've planned your whole life around it, that is something that one needs to preserve. But I think people who are younger and who recognize the fiscal instability of the program are much more open to gradual changes that preserve the financial benefit and the structure overall, but make reasonable adjustments again for younger Americans. The public polling all shows that raising the eligibility age for Medicare is something, of all the different Medicare reforms you could choose, that's one that has historically been among the public is most amenable to, and it's especially from a policy standpoint an attractive approach when you have the ACA exchanges to ensure that low income and low to middle income people still have health coverage.